Mike Stone is going to talk on the current strategies to minimize spinal cord ischemia and TAA repairs, endo and open. All scenarios. Yeah.
All scenarios, right. All right, so thank you for the introduction again, and let's get on with it. So thoracic repair and paralysis is the dreaded complication outside of mortality. It's 6 to 37% of cases in the setting of rupture of complex aneurysmal anatomies. And the strategies I'll go over today briefly are around preservation of segmental blood supply, hypothermia. I won't touch on that much about cord hypothermia, but that has been described. CSF drainage, which I think is still controversial in the endovascular realm, and I'd like to hear what the panel has to say about that. Use of shunts, and then on the horizon, pharmacological agents that exist. But essentially, the ischemic event is a hypoperfusion of the cord. And there are really kind of two etiologies for that. There's simple just disruption of segmental supply, an infarct of the cord that we see. And more so now in endovascular repair, we do see embolic events to the cord as well. And you can see even DW MRI hits akin to the session we just had in carotid disease happening in the cord as well. This leads to cell death, apoptosis, and long-term cyst formations in these necrotic areas. The clinical recovery is related to not having it happen in the first place, obviously, and then rescuing the penumbra of threatened tissue around the infarct. So the foundation of treatment is to maintain cord oxygenation in recognition of the rich collateral network to the spinal cord as well, and the preservation of these branch vessels, the first order aortic branch vessels that then lead to these collaterals. And prophylaxis is based on improved oxygen delivery and decreasing demand. So what are the high-risk anatomies? Well, it's degree of T-bar coverage or degree of surgical replacement. Obviously, then there's the branches I mentioned, which is subclavian IMA status, hypogastric occlusion, then the presence of embolic sources like a shaggy aorta, and of course, prior aortic surgery and other patient factors such as renal insufficiency in terms of physiology. So if you start to look at what people have started to realize with thoracic repair, and I'll get into a VQI study that shows the trend of drainage with endovascular repair as well, but there was a more common endovascular drainage, more common drainage practice in endovascular cases over time, and then people began to develop selective practices. And this is a paper from Will Jordan at Birmingham that developed selective practice of spinal drainage. And he had 16 cases in his series of 266 cases of paralysis. And then those were either drained or not drained and had recovery, partial recovery, or no recovery, and similar ratios in those. But the important part is that with spinal cord ischemia in the endovascular population, there's a 56% one-year mortality. So we all know it's a dreaded complication. In terms of timing of the deficit after endovascular repair, immediately post-procedure, this occurs in 43% of cases in this series from Germany, and then the rest were basically within 24 hours and very seldomly after 24 hours. Probably many in this room, including myself, have had very late occurrences, even very late, as in months later, with things like dehydration and illnesses, or during things like dialysis runs in the hospital weeks later after complex aortic repair. So what about anatomy? So as you move more proximal in the aorta, this is an old NISQIP study we did, as you move more proximal, you have worse neurological outcomes. So the simple repairs in the descending thoracic aorta, you can see there the paralysis rate in NISQIP is a little bit less than 5%. And this is a dated study. It's about 10 years ago when I wrote this paper. And then as you cover the subclavian, visceral vessels, the dark green, the second bar in the histogram is the neuro event rate. And the arch has the worst rates of both neuro event and then also composite of mortality and serious adverse event. So what are things that we do in our practice now to try to decrease or mitigate the risk? We do believe in both open and in endovascular cases of using intraoperative monitoring techniques. So we use transcutaneous motor evoked potentials. Of course, in the endovascular cases, if you do that, the large sheath causes a drop in the MEPS almost like clockwork around 40 minutes after the large sheath is placed. And that's not just the ischemic event, the large sheath, you also may be occluding some of the collateral network to the cord as well. So it becomes part of the rescue if you have a problem. In open thoracoabdominal aneurysms in our practice, the 1, 2s, and 3s that we do, And then largely, these have been replaced by endovascular means. We do use the MEPs to help us guide the intercostal plan. So if we have a questionable intercostal pair, we do want to implant as much as possible. But if we're not sure about it, we'll use a pinch bulldog applied on the intercostals and watch the MEPs and see if that pair should be reimplanted. And then we make sure all the pairs we've decided to sacrifice, we clip externally before opening the aorta so there's not an air sump to cause pressure changes in the cord, or even, I guess, air embolus going the other direction. Endovascular thoracic repair, motor changes that happen with the MEPs, it's about a 75% decrease that you see. We aggressively treat this with hemodynamic management in the operating room, so making the patient hypertensive and actively transfuse for hemoglobin above 10 using point-of-care blood gas testing. Provisional staging is a very good idea, and I'll show you some data around that in just a minute, but provisionally staging this, or actually planned stage rather instead of provisional staging. I guess you would provisionally stage if you have the MEP change, but planned staging does result in a lower spinal cord ischemia rate. So this is a paper from Matt Eagleton that looked at spinal cord ischemia rates based on single repair. This is endovascular complex aortic cases. So single stage repair, provisional, and then planned stage. And the dotted line at the top of the Kaplan-Meier curve for the event rate there are the patients who underwent planned staged repair. So planned staged repair, and these data have been replicated in the ARC data set and in other large data sets, is safer for reducing the risk of spinal cord ischemia. So what about, I'll get to drains in just a minute, what about other intraoperative physiology maneuvers? Propofol-based anesthetic and avoidance of hyperglycemia seem to be protective, and avoidance of narcotics. So all those agents have been implicated in a GABAergic or excitatory pathway in terms of causing damage to the spinal cord. And obviously, concise communication of hemodynamic goals to the anesthesia team throughout the case, and aggressive monitoring of those hemodynamic goals. Hyperoxygenation of the patient, maintaining high SATs and a hemoglobin above 10 at all times during the case. Dr. Caselli already presented this in his slide at the beginning of the session, but the randomized trial in the open operations did demonstrate an advantage to drainage versus not drainage. So what about in the endovascular group? So these are VQI cases of patients undergoing complex endovascular aortic repair and TEVAR. And in the dark line at the top, you can see the instance of preoperative use of a spinal drain. So sort of peaked around 2015, then downtrended as people probably adopted a more provisional status around that. And then you can see postoperative therapeutic drainage. And those are, in other words, are cases that have a problem and are getting a drain. So these data are hard because they're just, it's what's happening in the real world. But if you look at factors associated with spinal cord ischemia, it's male gender, non-white race, Crawford extent 2, so extent of disease, and then the lack of a prophylactic drain. Now, of course, that means those are the patients who got paralyzed who are getting a drain, so the data are hard to be causal in nature, but it does suggest a protective nature of pre-procedural drain in patients of high risk. Now, drains aren't without complications, and I heard some people on the panel mention this earlier. This is the graphic abstract summary from Gustavo's paper from the Mayo Clinic, which demonstrates the drain complication rate in spinal cord injury related to drainage of 31%. And while we haven't realized one that high at our institution, but that's probably, he's a higher volume operator, and that is a real number to believe. We have certainly had sheared off drains, hematomas, and all that. So when we drain patients, we do it the night before. So our best practice is to bring patients in and drain them the night before in case there's a problem with the drain. For open cases, we drain all cases except for extent 4 cases. And then I think you need institutional specific guidelines for endovascular cases. I think Vinky mentioned in his case about he has to call radiology to put a drain in. So I think it depends on what your rescue protocol is at your institution, how aggressively you can get a drain in. In our site, it's a neurosurgery chief resident call, and it's sort of a code stroke. I think Dan mentioned something like that earlier as well. We tend to do a lot of these under fluoroscopic guidance if there's any problems, especially the ones that come in planned the night before. If you come in planned the night before and you get bloody drainage, we defer the case. But it requires education and aggressive troubleshooting if there's problems. A couple other slides. I know I'm a bit over time here. Postoperative monitoring in our institution is obviously the Q1 neurovascular checks that all patients have. We look for rector femoris muscle function, so it's raising the knees off the bed. It's not the toe wiggle. We maintain the hemoglobin above 10 at all times for the first 48 hours. We actively correct the consumptive coagulopathy that you see in open and endovascular cases, the fibrinolytic process, so that we're able to place a drain if we need to, and also that fibrinolysis causes a DIC type picture. Liberal use of IV fluids, and the pressors are kept at the bedside. So what happens if you actually have it if you have a spinal cord event at our institution? Well, we have an emergent call, obviously, to the vascular surgery and the ICU faculty. MAP elevation to 100, 120 millimeters of mercury with fluid and levofed. And with the goal ISP then of drainage, the goal ISP of less than 10, drain 5 ml increments, and we do not drain more than 20 cc's in an hour. We start supplemental oxygen and again transfuse as needed. And we start the CW active protocol with naloxone. Pharmacotherapeutics on the horizon, there's a lot of literature on this. This is an old DOD study I took part in of looking at oxidative damage from ischemic damage to the spinal cord, and we actually put Viabons in rabbits' thoracic aorta to make them ischemic. So I have the audio off because I'm yelling at the resident about where to put the Viabon on a Saturday morning in the research lab. But basically, we demonstrated that aggressive oxidative damage happens to the spinal cord when you cover it with a stent graft, and you can rescue that damage with preoperative treatment with PAR inhibitors that stop ATP consumption. So these are agents on the horizon for MI and stroke rescue. They may be able to be given prophylactically to patients undergoing thoracoabdominal reconstruction. So in conclusion, sort of similar strategies open in endo. We need to look for pre-procedural risk assessment and optimization to maximize blood oxygen delivery to the cord. There is definitely a role for staged repair, and staged repair should always be the standard in non-emergent thoracoabdominal repairs undergoing endovascular strategy. Drain for open reconstructions, rarely for extent 4 without really high-risk anatomies. And then an institutional specific drain management protocol. If it's hard to get a drain in at your site and you're doing an endo repair and you're worried about it, you probably should put a drain in preoperatively. If you have a site where a drain can be put in rapidly, you can go down the pathway of provisional drain placement, and you need to have a rescue protocol. Thank you.